Hi, class. This is Dr. Weaver, and I am going to do a voiceover on um, care of patients with problems of the central nervous system, that is, the brain. This does come from chapter 42, so of course, make sure you do your assigned readings for this chapter. I believe Alzheimer's and Parkinson's is also in this chapter, but although you won't be tested on that information for this term, because you did have it last term, but just a quick review of it wouldn't be a bad idea, especially since you might see this information on your HESI, your HESIs that will be forthcoming, of course. Go ahead and read your objectives at your own leisure. I won't go over these for you, but they are fairly easy to understand. So just take a look at these. Some priority concepts in this chapter: cognition, mobility, and the interrelated concept in this chapter is comfort. Right. So on page 876, I believe that is the page that starts with seizures versus epilepsy. So actually, we will be covering seizures, epilepsy, as well as meningitis. So seizures can be generalized, they can be partial. There are also some unclassified types of seizures, and they account for half of all seizures, and the etiology of the cause is unknown. So they don't actually fit into the general partial categories. Also, as far as epilepsy, it can be the primary or idiopathic, meaning they don't know why, the cause basically. And it is not associated with any identifiable brain lesion or other specific cause. However, genetics might play a role here. So, what is a seizure? A seizure is an abnormal, sudden, excessive, and an uncontrolled electrical discharge of neurons within the brain. It may result in change in mental status, as well as motor and sensory ability, and also behavioral changes as well. Now, there are 5 types of generalized seizures occurring in adults, and both brain hemispheres are involved in these disease processes. There's also something we call a tonic-clonic seizure, and this seizure lasts for about 2 to 5 minutes. The tonic phase means muscle stiffening, rigidity, especially of the arms and legs. And there's also immediate loss of consciousness with this type of seizure as well. Now, the clonic or the arrhythmic causes jerking of all extremities that follow the tonic phase. So you have the tonic phase initially, and the clonic phase follows. It does follow. Other signs and symptoms to follow: the patient may bite their tongue. They may become incontinent of feces as well as urine. These patients may also become fatigued. Acute confusion might occur. The patients might experience lethargy, which may last up to an hour after the seizure. Sometimes these patients will have only tonic or clonic, so they may not have both. So just make sure you're looking for that as well. Now, there is also a type of seizure called a partial type of seizure. It is also AKA or known as a focal or local type of seizure. These actually begin in a part of one cerebral hemisphere of the brain. Seizures can be further divided into a kind of subdivisions. two main classes. The one is complex partial, and the other is simple. Now, these type of seizures are seen mostly in adults, and they are less responsive to treatments compared to other seizures. Now, with the complex type, look for patients blacking out. There may be loss of consciousness or syncope, for 1 to 3 minutes. These patients, they might be unaware of the environment. They may kind of wander around at the start of the seizure. Now, after the seizure, they might have a loss of memory or a kind of amnesia. The temporal lobe is often affected in this type of seizure as well. Now, there's also a simple partial seizure. These patients are conscious throughout the seizure episode, and that's the key, they're conscious. They might experience what we refer to as an aura before the seizure, and this is basically an unusual sensation. This aura might consist of what we refer to as a deja vu, something that has already been seen before type of phenomenon. There's a perception of offensive smell of these patients might experience, or a sudden onset of pain as well. Now, an aura is known as, or it occurs in the pre-ictal phase because it occurs before the seizure. Now, after the seizure, it would be known as a post-ictal period. So the pre-ictal is before the seizure, and the post-ictal is after a patient has had a seizure. Other symptoms, the patient might have one-sided movement of an extremity. They might experience unusual sensations or autonomic symptoms as well. Now, when I say autonomic symptoms, we're talking about dizziness, fainting upon standing up, or orthostatic hypotension as well. Seizures may result from several medical conditions. The patients may have a metabolic disorders, acute alcohol withdrawal. There's also electrolyte disturbances such as a low potassium, low blood glucose, water intoxication, which occurs when people drink a lot of water. These seizures can also occur from a heart disease. The patient can have a high fever. Also, the patient can have a stroke, as well as substance abuse is another risk factor for seizures. Now, seizures resulting from these causes are not considered epilepsy, so don't get those confused. Let's see, so other risk factors that can trigger a seizure can be increased physical activity, believe it or not, emotional stress rather, excessive fatigue. I talked about alcohol withdrawal, or just alcohol can also lead to seizures, caffeine consumption, or certain foods or chemicals might also cause a patient to have a seizure as well. As far as interprofessional collaborative care for patients with a seizure, there are certain equipment that the nurse must consider. For example, the patient should always have oxygen at the bedside, ready to be administered. Especially when they begin to have seizures, you want to be able to place oxygen on them because they're not breathing normally like an ordinary person would breathe. So just make sure there's oxygen present so that the patient may not experience any respiratory compromise. There's also a need for suction equipment, and this is to prevent any aspiration, particularly aspiration pneumonia, which could actually kill the patient. We want to also make sure the airway is or remains open. Remember your ABCs. IV access is also important because these patients will need intravenous or parenteral seizure medications like IV Dilantin or IV phentoin. Site rails may also should be up and also padded, but I will say with respect to this particular intervention, make sure you check your agency's policy regarding all site rails up, because in some agencies it may be considered full restraints. So just make sure you check your agency's policy on that. I want you to also read chart 42.8 on page 878 for how to properly care for a patient with the tonic-clonic seizure. My computer is doing something crazy, so I'm a little concerned about what it might do on me. Let's see, as I mentioned, padded side rails can be considered restraints or may cause embarrassment to the patient and the family. So again, check your agency's policy on that. As far as seizure management, well, it depends on the type of seizure. Observation and documentation is going to be important, and I want you to look at chart 42-9, page 878, for proper ways to document a seizure. Patient safety is always first and foremost. These patients should be also placed in a sideline position in order to prevent aspiration pneumonia. No restraints. You never want to restrain a seizure patient. Can cause injury for these patients. And you never want to force anything into the mouth of these patients because you could break their teeth. Now, as far as observation and documentation, what we're looking for are things like how often seizures occur, a description of the seizure, and also if more than one type of seizure has occurred. And there's some additional information there I would like for you to read. As far as acute seizure management, we are now getting into the drugs that these patients might require. The medications will depend on the type of seizure. Medications for tonic-clonic seizure activity may include lorazepam, or AKA Ativan, diazepam, or AKA Valium, Diastat, IV phentoin or Dilantin, or phosphophentoin or Cerebix. Please also look at table 42-5 or 42.5 for common drugs that are used to treat seizures. These are known as anti-epileptic drugs, or also we refer to it as AED. Not the AED with the paddles, but AED as in anti-epileptic drugs. Want to teach these patients to take their medications on time. This will help maintain a therapeutic level and also maximum effectiveness so that they won't have another seizure. They should be taught to take these medications as prescribed. Also remember, depending on the state where this patient resides, it determines when the patient can drive again. So the patient may not be able to drive for a year. I want to say 6 months to a year. And these are things that the patients will have to be taught as well. These patients should also be taught that as they age or become older, they might build up a kind of sensitivity to these anti-seizure medications. If they do, the healthcare provider will have to titrate the drug upward um, in order to give them a more therapeutic effect and prevention of seizures. They would need more frequent monitoring when this occurs because of this. So keeping appointments in order to check the serum blood levels are paramount. Um, there are some foods and other drugs that should not be given with anti-seizure meds such as Coumadin. Should not be given with Dilantin, and also grapefruit juice can interfere with the metabolism of these drugs, or some other fruits can actually raise the drug levels, leading to toxicity. So we have to teach these patients about these types of foods that they should avoid. So the next topic we will cover is status epilepticus. Epilepticus, status epilepticus. That's a kind of a funny word. Um, anyway, so what is status epilepticus? Um, these are actually they're seizures, but they're prolonged seizures that last more than 5 minutes, or repeated seizures over a course of 30 minutes. This is a medical emergency. These patients can lose their airway and stop breathing, and they can have some significant issues. We want to always establish an airway with these patients. Because they're not really breathing normally, ABGs should be drawn from these patients because they're not breathing. They can easily go into respiratory acidosis. These patients, as far as drug of choice, DOC means drug of choice. We want to push IV lorazepam and also diazepam. If they do not have an IV access, then rectal diazepam will have to be administered. These patients will require a loading dose of IV phentoin or Dilantin. Take a look at page 879. It talks about the status epilepticus. This is an acute seizure of greater intensity, essentially, number or length of time compared to the usual seizures. If the seizure lasts more than 10 minutes, it can cause death. As you know, the brain cannot go without oxygen for more than 5 minutes before someone can become brain dead. Common causes of this type of seizure: there's sudden withdrawal from anti-epileptic drugs, also infection, ETOH, meaning alcohol or drug withdrawal as well. Head trauma can also lead to status epilepticus, cerebral edema, metabolic disturbances. If this is left untreated, this can lead to metabolic changes, namely metabolic acidosis, hypoxia. Of course, this is what can lead to metabolic acidosis. Can also lead to hypotension, hypoglycemia, and also cardiac dysrhythmias. And again, as I said, metabolic acidosis from the lactic. It's really lactic acidosis, but it's a metabolic component. Again, they're not breathing. So, of course, lactic acid builds up when you don't have enough oxygen in your body. During these episodes, what happens is muscles break down, and because of the breakdown, it creates what we call myoglobin, which accumulates in the kidneys. And this can lead to renal failure and also electrolyte disturbances or an imbalance as well. And I don't know what my system is doing. It's like it wants to go off. Now, when giving Ativan, It's usually 4 milligrams over, this is our loading dose. We give it over a 2-minute period. The maximum dose that these patients can receive is 8 milligrams. The patient should be taught that serum drug levels are checked every 6 to 12 hours after the loading dose. Then 2 weeks after oral phenytoin is started. The desired therapeutic range is between 10 to 20 mics per ml. If they are greater than 30 milligrams per milliliter, this is considered toxicity. So this is why they should be monitored frequently to ensure that they don't go into they don't receive a toxic dose of this drug. So we want to evaluate most current blood levels of these medications. We want you to also teach these patients to beware of drug to drug or drug to food interactions. We also want to maintain a therapeutic blood level for maximum effectiveness. And again, we don't want to administer phenytoin with warfarin or Coumadin. Also document and report side effects or any adverse effects these patients may have from this drug. Now, when these patients they don't do well on the medications for seizures, surgical management or surgical procedures might be warranted in this case. These patients might need what we refer to as a vagal nerve stimulation for epilepsy. Now, all right. So patients with vagal nerve stimulation for epilepsy has responded actually well to this procedure, but only for the simple complex partial seizure types. Patients with the generalized seizures are not candidates for this particular surgery due to the potential for severe neurological deficits. If you can please read page 879 for how the vagal nerve stimulation procedure is actually performed. And there's some additional information I want you to read there. Now, patients with the vagal nerve stimulator can activate this device with a handheld magnet. If they get that warning that a seizure is imminent, if they get an aura, basically. And this will, of course, abort the seizure. So again, sometimes they get this warning, this aura that I spoke about on a couple of slides back. And this can hopefully abort the seizure before it occurs. Now, as the vagus nerve is stimulated, these patients will also experience a change in the quality of their voice. So this is something that they need to be taught, warned about as well. Now, the most common complication is voice hoarseness. Also, read page 880 about conventional surgical procedures for these patients. On the second paragraph, read the section that starts with before surgery. And what this does, it talks about the continuous EEG and other procedural steps prior to this surgery. The big things is patients are taken off their anti-epileptic drugs before monitoring. They do these a lot at UF Shands, Jacksonville, by the way. So As far as conventional surgical procedures, this would include patients with complex partial seizures in the frontal and temporal lobe. There's also an anterior lobe resection procedure to treat seizures. There's also a partial corpus callosotomy. This is where the surgeon sections or resections the anterior 2/3 of the corpus callosum. As far as care coordination and transition management, um, we want to make sure these patients are compliant with their anti-epileptic drugs. We also want to get social services involved so that they can provide adequate resources for these patients, especially if they require some assistance with their medications, because the cost can be a bit high for these patients. We want to also evaluate these patients' employment status, because some of them may have jobs, for example, construction, or they may be operating dangerous equipment. They may be pilots. I think I had a patient years ago who actually had a job as a pilot, and I'm forgetting what the diagnosis was, but basically, when someone has seizures, you don't want them flying in the air, obviously, or operating dangerous equipment. So this has to be evaluated. Patient may have to be on disability until they've at least been on anti-seizure meds and without a seizure for a certain period of time, 6 months to a year in most cases. So vocational rehabilitation may be subsidized because they may need other employment. They may not ever be able to perform certain jobs again. Let's see. These patients can be referred to Epilepsy Foundation of America for more information, and also for community support as well. So the next area we want to look at is meningitis. So I believe this starts on page 880. As far as a pathophysiology regarding meningitis, the organism that cause this condition, whether it be bacterial, fungus, viral, it enters the CNS, or the central nervous system, by way of the blood, and also it can be introduced directly into the CNS, such as with brain injury or trauma and whatnot. So a direct cause would be like a penetrating head trauma. Surgical procedures on the brain or the spinal cord can also lead to meningitis. Well, also rupture of a brain abscess. That organism within that abscess can also affect the meninges. Infections from the eye, ears, nose, and mouth can also lead to meningitis because of its proximity to the brain. Viral meningitis is the most common, or it's also called aseptic meningitis, because no organism typically is isolated or identified from the culture of cerebrospinal fluid. Common viruses might be HIV, chickenpox, herpes, enterovirus, and also mumps. There's also a fungal type of organism. The common one is Cryptococcus neoformans. Now, when we get into the pathophysiology of meningitis, it's essentially an inflammation of the meninges of the brain and spinal cord, especially the pia mater and the arachnoid portion of the meninges. And let's see, we talked about viral, bacterial, other causes, fungal, as I mentioned, protozoal, organisms, cancer, drugs such as NSAIDs. Also antibiotics can cause this, and also IV immunoglobulins. So regardless of the cause, the symptoms are fairly similar when we especially talk about the neurological symptoms that these patients experience. Now, these are just some signs and symptoms that should be considered. The general symptom would be fevers, but as far as the neurological symptoms, these patients might experience a headache, photophobia, indications. It may cause increased intracranial pressure, also nuchal rigidity, which is when they actually take the instruct the patient to touch their chest with their chin, and it causes neck pain. There's also a positive Kernig's and Brzezinski's sign, which we'll go over. And there's also decreased mental status, focal neurological deficits, and the patients may experience some GI symptoms such as nausea and vomiting. Please look at page 881, chart 42-11 for some additional signs and symptoms. As far as positive Kernig's sign, now what this is, we're looking at severe stiffness of the hamstrings, which causes an inability to straighten the leg when the hip is flexed to about 90 degrees. That is your Kernig's sign. Then we talk about Brzezinski's signs that may be noted as well. This is where the patient has severe neck stiffness, which causes the patient's hips and knees to flex when the neck is flexed. There's also a focal neurological deficit. This is a problem with the nerve, spinal cord, or brain function. It affects a specific location, such as the left side of the face, maybe the right arm, or even a small area such as the tongue. Speech, vision, hearing problems are also considered focal neurological deficits as well. We want to watch for early signs and symptoms of increased intracranial pressure, such as a decreased level of consciousness. These patients are at risk for developing a seizure as well. There's also, we want to do a complete vascular assessment at least every 4 hours to detect any vascular compromise. What happens in this condition, these patients have a thrombotic or embolic complications, mostly seen in these conditions with meningitis. So it's most commonly seen in the circulation to the hand. And so because of that, the embolic of the blood clots, we want to evaluate the hand for temperature, color, pulses. Want to also check capillary refill in the fingernails. If vascular complications are left untreated, this can lead to gangrene and a loss of limb for the patient. And these are just some laboratory assessment tools that are used to determine the cause of meningitis. We use a CBC. We also look at the CSF fluid or cerebrospinal fluid, and also a CT scan of the head is used as well. The cerebrospinal fluid, the analysis of the fluid includes a cell count. There's a differential count. And also we're looking for proteins in the CSF fluid. Also glucose concentrations can be fairly, I believe they're more higher in cerebral, though it could be, I have to check this out, but I believe the glucose in the CSF would be lower, but the BMP glucose would be higher, and I might have that reversed. Check back with me on that. Also, CNS is also done on the CSF fluid, and also gram stain studies as well, trying to identify the source of infection. So a gram stain and cultures are taken also from urine, from the throat, as well as the nose, um, because this could be the cause of the infectious organism. X-rays also done of the chest, also the air sinuses, and also mastoids to determine the presence of an infection. Remember, some of these areas are pretty close to the brain and can affect the meninges. But the CSF analysis is the most significant one that is used to diagnose meningitis. The CT scan is done for patients who are older than 60 years of age, and if they are immunocompromised, or if they have signs and symptoms of increased intracranial pressure, um, and they will need the CT scan before an LP, lumbar puncture, is actually done. Blood cultures, they might, or rather, these patients might need blood cultures to identify the organism, the causative organism. A test called a counter immunoelectrophoresis. And this assesses for viruses and also protozoa in the CSF fluid. Also, there's a polymerase chain reaction test that is also done in this as far as a diagnostic workup. These patients may also have a CBC. Usually we're looking for an increase in the white blood cell count, which indicates an infection. And also an X-ray to determine the presence of infection, as I mentioned earlier as well. As far as drug therapy is concerned, initially broad spectrum antibiotics might be used until they can identify or isolate a specific organism. These patients may also have hyperosmolar agents such as mannitol. This is used in the treatment of increased intracranial pressure. It basically draws a little fluid from your cells, because once the cells become increased or edematous, this of course can lead to seizures. So the hyperosmolar, or this solution that has a hypertonic content, can drain some of that cerebral swelling that these patients may experience, which can lead to, of course, increased intracranial pressure if left untreated. Anticonvulsants may also be used, particularly prophylactically. Steroids are also used. This is controversial. It is better to use steroids for patients who might have S. pneumoniae type of meningitis. There's also prophylactic treatment for those healthcare providers who are in close contact with patients with meningitis. One of the prophylactic treatments would be rifampin. In addition to that, Cipro and Rocepin may be prescribed as well, just in case you are exposed. Thorough hand washing is still of paramount importance to minimize spread of infection, and this is to include the family as well. Patients with suspected bacterial meningitis, they are placed on droplet precautions. They are also placed in a private room, and you should stay at least 3 feet from the patient unless you're wearing a mask. And of course, if the patient must leave the room, they should be wearing a mask as well. And that is about it. So not a very long presentation. Take a listen to it. Hopefully it will help you to understand seizures, epilepsy, as well as meningitis a whole lot better. Thank you. This is Dr. Weaver.